but we highly suggest that we don't, okay? Because there are some women who like to wear the panties way up here, the granny panties, okay? Interesting. So granny panties, because the elastic kind of acts like a compression, and you can also see that on a radiograph. We want to, if they are wearing underwear, make sure it's below their waist. More importantly, below what?
Bladder.
Pubic symphysis, because that's where the bladder is. We're looking at the urinary system. Oh, I thought somebody had a question. Okay, all right. So everything, again, they can keep their underwear on, okay, but it should be below the symphysis pubis. No bra, no elastic around the waist, okay? There's two scalp films that you're going to take. The first one is a KUV. What's a KUV?
Kidney reader bladder.
Yeah, it's just an abdominal shot, right? Where are we going to center?
Iliac crest.
Iliac crest. What size image receptor?
14 by
14
17.
by 17. So you guys already know this, okay? Here's a new one. You also got to take a scalp film of just the kidneys themselves. Remember, about 50 slides ago, how do we find the midline of the kidney? Between what and what? L1, L2, okay? It's between the xiphoid process and the iliac crest. You're going to be using a smaller image receptor, okay? Because this is what we're trying to do. We're just taking a shot of the kidneys. So you're going to use a smaller image receptor going crosswise. So 10 by 12, 11 by 14 crosswise. Taking two scalps, a KUB and a scalp for just the kidneys. Okay? Now, this is where it gets a little bit sketchy. Did Ms. Smith discuss tomograms with you? Okay. Oh man, it's going to be a lot of explaining to do. Okay. Okay, this is what a tomogram is. Because one of them is going to be your scalp, is a tomogram. Okay, here's the table. Here's your patient. Okay, here is your image receptor. And let's just say here's your X-ray tube. Okay, you guys follow so far?
Mm-hmm.
The X-ray tube and the Bucky tray, where the image receptor is physically connected together. Okay? We connect the X-ray tube to the Bucky. It's connected. So if you look back over here at this image, this X-ray tube, this is locked into the table Bucky. Okay? We have control of that. We can engage it, we can disengage it. In this, so what we're going to do here is we're going to engage this tube to the Bucky underneath. All right? So, what a tomogram is we're going to put the X-ray tube in what we call zero position. So that means that this tube is going to be over here. It's going to be over here now. And because it's connected, where do you think the Bucky is going to be? The Bucky is going to be over here now because they are connected to the Bucky. You guys follow? When we make an exposure, this tube is going to swing from top to bottom. And as that tube's moving, so is the Bucky. So it's moving like this. Okay? It's going like this. What is the objective of that? Okay? We're literally taking an X-ray in motion. We're taking an X-ray in motion because as it's making exposure, it's going beep. And this is also going opposite direction. The X-ray image that you get is blurred, except at the fulcrum, the point, the center of this X-ray tube in the bucky is your fulcrum. So anything above or below that image, except at the center of the fulcrum, is going to be in focus. It's called a tomogram. There's a lot more to it than that, but we don't have time. Okay? So again, you're taking an X-ray. We call it a sweep. When you make an exposure, the X-ray tube sweeps across. Okay? So that is why when you look at this image here, when you look at this image here, it looks like there's motion. Why isn't my thing working? Okay, so when you look at this image here, it looks like there's motion. So anything above that fulcrum point that you select, because you can change that fulcrum. You can select the level of that fulcrum or that point of rotation. You can adjust that. So anything above or below that fulcrum gets blurred out, and anything at that center of that fulcrum stays in focus. So anything above that level and below that becomes blurred again, but at the level of the fulcrum stays in focus. And this is what the tomo portion of the scalp film is all about. So you're going to take a KB, you're going to take a tomo, bless you, of where that kidney is, and that's going to be your first 2 scalps. Okay? Now, when you're all done, taking your scalps, showing them to the doctor, now you're going to begin your study. You've got all your IV equipment set up. You're ready to do your venipuncture. And once you get venipuncture, once you've got access, now you are going to inject the contrast material. Okay? As you're injecting the contrast material, note the time when you started injecting. Okay? Note the time that you started injection. Also, as you're injecting, you're not doing it fast. You're doing it slow because you want to make sure. Is everything okay? How are you feeling? You doing okay? Okay, good, okay. Well, hang tight. I've almost got the contrast in. How you doing? You still doing okay? Good. How about now? Are you still doing okay? You're constantly checking up on them, okay? And as you're injecting, you're also checking the site to make sure that there isn't any what? Extravasation, okay? So you're watching your patient for any type of response or reaction. You're looking for extravasation. And you also noted, because you're looking at the clock, the time you started the injection. Okay? Because the very first shot that you're going to take is this nephrotomogram. Okay? And it has to be done right here, 60 seconds right after your initial injection. Because what we're looking at here is we are looking at the collection of contrast in the nephrons. We're not talking about the collecting system. We're not talking about this. We're not talking about the calyces and the pelvis and the pyramids. We're talking about the collecting system where the nephrons are located at the cortex. And what happens here is the renal parenchyma starts to blush. I don't care about the collecting system yet. I want to see how my nephrons are working. So you're going to see some blushing of the kidneys, the renal parenchyma, in the first minute. And that's the very first shot that you're going to take. Now, if I'm thinking what you're thinking, you're hoping you don't have to do a tomogram because it sounds complicated, right? Mm-hmm. There's also the option, again, it depends on your facility, there's also just taking a straight-on shot of the kidneys. It's just a nephrogram. But again, you get better images if you do a nephrotomogram. But whatever it is, it's either, for your first shot, 60 seconds after the initial injection, you're either going to do one or the other. Okay? If you end up doing a nephrotomogram, okay, as part of the series, there are 2 more shots that you need to take. So I'm going to back up here a little bit. How do we find that fulcrum, that center point? Remember the center point? How do we find this? The center, okay?
Half the SID.
So what you're going to do, is you're going to take your caliper, measure from front to back. You guys follow? You're going to measure from front to back with your caliper. So let's just say I measure 24 centimeters from here to here. That would make me very skinny. If I'm from here to here, 24 centimeters, what you're going to do is you're going to divide that by 3. Divide it by 3. And remember, I said that you can adjust that. It's a switch that you just go up and down. It's automatic. Go up, the fulcrum goes up. Go down, the fulcrum goes down. There's just an adjustable button. You're going up or down, but you're going to adjust it. If I was 24 centimeters, what is my fulcrum going to be? It's going to be what?
8.
It's going to be 8. Okay, so it's going to be 8 cms. If you are doing nephrotomogram, there are usually 2 other shots that you have to take, 2 more nephrotomograms. You're going to do one at 1 centimeters below. So you're going to adjust it to 7, and then you're going to take another one at 1 centimeters above. And that's why you got to be quick in doing this, because we're looking at the initial filling of the renal parenchyma. Okay, so thickness divided by 3 to calculate the fulcrum level. Add 1 if on a thick pad. So in other words, if I measure 28 and I'm laying on a thick pad, I'm going to make my calculation based on 29 divided by 3. Or round it off, so it'll be like 30 divided by 3. That's a lot easier. Okay, so then I would do it at 10, 1 at 9, and another one at 11 for my nephrotomograms. Okay. Then your next shot, what it's going to be, is going to be your 5-minute shot, AP, supine. Again, there's your KUB. These are all KUBs now. This is a simple part. This is like the small bowel series. Remember small bowel series sounded like very, very complicated? When all it is just a series of KUBs. This is just a series of KUBs. So now you have your 5 minutes. You have your 10 to 15 minutes, depending on your protocol. Then at 20 minutes, you're going to do your obliques. Full KUB obliques. You're going to do your RPO. You're going to do your LPO. What is the purpose of the obliques? Remember how your kidneys lie? Yeah. So, RPO, LPO, to get your kidneys in profile at 20 minutes. Okay? And then lastly, you know, when the doctor says, yeah, go ahead, we're done, you have them go pee, and then you take your last shot, which is your post-void. Just like your post-void in the VE, you also have a post-void in your IVU. And again, it depends on the protocol. Your protocol is, are we going to shoot it on the table? Most places that I've worked, we did it upright, an upright post-void. Because what we're looking here now is we're looking at the bladder in an upright position to see if it's prolapsed past the pelvic region, the symphysis pubis. Okay, we're going to talk a little bit more about this in just a minute, but that's the routine. Okay, inject. First shot is going to be your nephrogram or your nephrotomogram. You can't do any of this before you've determined where your fulcrum is and you've determined what your technical factors are, because it's going to be quick. You better have everything set before you start that injection. Okay, so make sure you got the right start of time, the contrast. This is, again, we already talked about this, so verify the contrast that you're going to use, lot number, expiration date, the amount, site of injection, consent form. Okay, we got that. Do not leave the patient alone. The radiologist should remain within the immediate reach for about 5 minutes. That just means like in the next room. Okay. First 5 minutes. They can't be going to the cafeteria. They need to be around in case something happens. With an easy reach for an hour. These procedures don't go an hour. They're usually done in about 15, 20 minutes. Remember these time sequences? They're usually done in about 20 minutes. Okay? Now, here is, I'm just going to throw something up in the air. So again, that's your normal routine. You're done with your 20-minute obliques. You're done with your, you're not doing your post-void. You're done with your 20-minute obliques. But you're not seeing the kidneys fill. You're not seeing the ureters fill. So that's usually indicative of the patient having a stone or a blockage. Now what? So here's the variation. Now you're going to take pictures maybe every 15 to 20 minutes, maybe 30 minutes. Remember the small bowel series when it wasn't filling up, like every 20 minutes intervals? We said once it goes past a certain hour, now you're doing it every hour or so. Same thing happens here with the IVU. If the kidneys aren't filling up, now the doctor may order just KUBs every 30 minutes or every hour until we see the filling. Okay, so those are your delayed studies. Okay, I'll go through that in just a second. Okay. So I put this up here again for you guys because here we have our basic views, and this is generally the order that we do it in. So after injection of the contrast, you're going to do your 1-minute nephrogram or your 1-minute nephrotomogram with the sweep. 5-minute AP, 10 to 15-minute AP, 20-minute RPO and LPO. There you go, P, do your post-void. Okay, prone. We do it either prone. Why do we do it prone instead of AP? Or, I'm sorry, supine?
Bladder
Put the
closer.
bladder closer to the image receptor, okay? All right. You guys know how to do that? I'm gonna keep on going. Okay? These are the nephrotomograms. So here's a larger picture. See how it's blurry? Because it got that motion. But what is in focus is that point of your fulcrum. This is all blurred out, and anything above it or below that fulcrum point is in better focus, okay? So timing is critical. Series of tomograms starting at 1 minute, and then again, you may do 1 centimeter below and 1 centimeter below, above and below that fulcrum. And then you do your routine right after that, which is your 5-minute AP. Then you do your 10 to 15-minute AP. Then you do your 20-minute obliques. But here is, you can actually see here they're getting ready to do a nephrotomogram. Remember I told you the tube starts here at this end, so tube's over here, Bucky's over here. When they make an exposure, it sweeps at the fulcrum point. So to do a picture of just the kidneys, central midway between the xiphoid process and the iliac crest at your mid-sagittal plane. I know you guys are tired, me too.
So only fulcrum point is blur, everything else is clear, or vice versa?
At the fulcrum point, it's clear.
So only at that point it's clear.
Only at that level.
So what's
So
the point?
anything that's above and below. Because look, when you are spinning a top, let's say you're spinning a top, okay? What stays focused is in the middle of that spinning top, but everything around that is blurry.
Mm-hmm.
So that middle is your fulcrum point, which stays more focused than the periphery. Okay. All right. So as you're doing these, make sure that you are using your appropriate level markers. Here are your posterior obliques. At what time do we do this?
20 minutes.
20 minutes. You're going to do your RPO, LPO. If you do your RPO, which kidney are we looking at?
The down kidney.
Right.
If you're doing an RPO, we're looking at the left kidney. Okay? So RPO, you look at the left kidney, but you're looking at the right ureter. Okay?
It's not okay.
There's an RPO. When you're doing an RPO, you're looking at the left kidney. So when you put them on, left kidney, because when you put them on RPO, this opens up the left kidney, but see, now you're not seeing the ureter, but you're seeing this ureter very well. Okay, so RPO, left kidney, right ureter.
But we see that kidney well too, right?
Well, yeah, but
The other one.
But you're not seeing the ureter.
No, I meant
This one, you're
the.
seeing it, but you're seeing it at an angle. You're not really seeing it flat right at you. You're just seeing it at a slight rotation. So the LPO or RPO, the posterior obliques, puts the kidney into true profile. Okay? You guys see anything unusual here? The squarish looking thing? What is that? Those are your compression paddles. Now whatever you do, whenever you're taking those KUBs, you want to make sure that the bladder is included. You don't want to cut off the bladder. You always want to make sure the bladder is included in any of your KUBs. Now if I'm looking at this, why did we cut off the bladder? Does it matter? And this picture doesn't matter because they have the compression paddles. Where's all the contrast? It's up here. There's not going to be any contrast down here because of the compression paddle. But in any other case, you want to make sure that you see the symphysis pubis. Okay? And then your post void. You're either going to do it prone, again, you center at the iliac crest, okay? Especially with the upright, you really want to make sure you get the symphysis pubis because we are evaluating for prolapsed bladder.
So she's still on the table, but table is moved?
Yeah, she's just standing up on a foot pedal, foot cord. How many slides do I have to go?
Too many.
Are you serious?
Yeah.
Okay. All right. So upright, looking at the bladder. Okay. Okay. I'm just gonna have you guys look through this on your own. Okay. We've already talked about this. There's no need for me to talk about this anymore. Okay. So compression paddle keeps the contrast up in the kidneys, right? Okay. Hypertensive IVU. This is just a variation of doing the IVU in that now, after your initial shot, you're going to be taking one every minute. One every minute for the first 5 minutes. Okay. If somebody has high blood pressure, one indication is that they're stressed. But another indication may be that one of their kidneys is stenosed. One of the arteries is stenosed. And that's something that nobody ever thinks about. I have high blood pressure. Well, maybe you have one of your kidneys that are blocked, that arteries are blocked off. So this is a test that we will do. So instead of doing the 1 minute and then waiting till 5 minutes to do the next shot, we're going to do 1, 2, 3, 4, and then 5. Okay? And if they're hypertensive, if there is an occlusion, the side that has the occlusion will fill a little bit longer. It will take longer for it to fill up. Okay, so contrast media is slower into one kidney than the other due to the blockage or narrowing of the artery. Okay, eventually they'll fill up over time. So hypertensive IVU is just you're taking those extra 4 KUBs. Okay, 4 KUBs in between. Again, it could be the KUB or it can just be just the kidney itself. But again, they're just 4 additional shots. All right, retrograde urogram performed in surgery. The contrast media is delivered retrograde through a catheter, so they need to be knocked out. You may be in one of these urographic rooms. Be familiar in how to use their X-ray equipment. Okay, this is X-ray equipment found in the OR. Okay, there's that catheter again. So they'll fill up the system of contrast through the catheter. Once they fill it up with the catheter, they're going to pull the catheter out, and then they will see its function. While the catheter is in there, it's a non-functional study. Once they pull the catheter out, now they can see it empty. Now it's a functional study. Retrograde cystogram, you have to cath the patient, urinary catheter. You know, when I was teaching at Chaffey College, they were being taught how to cath their patients. Yeah, that was part of their curriculum, learning how to cath their patients. Maybe we should do that here too.
Yeah, did they practice on
No, they practice on drugs. That's like the question of BE. Do we practice BEs on each other?
For extra
Or
credit?
maybe we should. I don't know. I'll explore that. We'll see if we can do that.
I'll give, but I shall not receive.
Okay. So you're doing a retrograde cystogram. We're doing for trauma, stones, and also inflammatory disease. Okay. Here is the key importance. It is also a non-functional study. Okay. The cystogram is a non-functional study. Oh, here's a change. Your slide said 15. That was so off. I don't know how that got in there. It should say 150, at least 150 cc's of contrast. Your slide says only 15. That would be only appropriate if your patient was a child. Okay, but normally it's 150 to 500. Okay, so what do we have here? Obliques and laterals of just the bladder. Also, I put down here for the cystogram, spot images under 4.0 may be conducted before your routine shots of AP and posterior oblique. In your AP, small image receptor, 10 to 15 degrees caudally, 2 inches above the symphysis pubis. And then if we're looking at the ureterovesical junction, again, this is the junction where the ureter and the bladder connect, UVJ, you're going to oblique them about 45 degrees. Okay, and center right on top of the bladder. 2 inches above the symphysis pubis, right at the middle of the bladder. And then also a lateral. Sometimes they do a lateral because on AP, the gonadus is getting a higher dose, so they'll do this as the lateral as an option. Not very common, but it's there if you want to do it. Again, about 2 inches above the symphysis pubis for that as well. Okay. All right, so 2 projections. It's either an AP, an AP and oblique or obliques, but 2 basic projections. Okay.
So that's why it's AP, because it's not superimposed in this way by pubic bones?
This which one?
Well, I mean, why AP, not PA projection?
Why not PA?
No, why AP, why not
because,
PA?
Because once you go PA, you got all that pressure there in the bladder.
Okay.
Yeah, it's going to be hard to hold that in. Yeah, and we are basically filling up to maximum capacity, so that if they put pressure on there, it may cause injury to the bladder, and that's why we don't do it. And that was actually a good question. That's why, in this case, we don't do it prone, we do it AP, because when you lay flat, you're going to put pressure on there, and you may cause a rupture of the bladder. Okay. The post void wasn't a big deal because the bladder was empty, and that's why we do it prone.
Okay.
That was a good question. Okay. All right. So read that. Now this is now if it's avoiding cystogram, the process is the same. We install the contrast via a catheter using gravity. Again, cystogram is non-functional. Voiding cystogram is functional because now we're going to have our patients pee. Okay, we're going to have them pee. So females, shorter urethra. Males have a longer urethra. There are, if we're doing a voiding cystogram, it's only one position for females. They're on their back, legs slightly apart, because we want the urine to drain out without them getting all messy between their legs. So they're gonna empty out in a receptacle, okay, a bedpan, and they're going to urinate. And the doctor again may be taking spot films, because that's a quick way of doing it. They may take spot films, or you may be taking these X-rays as they void, 1 or 2 shots. Okay. Now with males, okay, so one view for voiding for females. Male also one view, and the one view is a 30-degree RPO. We can't do an AP. We can't do an AP projection. They can't be supine because the urethra is just going to flop over. We need it to go off to the side so we can see the length of the urethra. And so we put them on a 30-degree RPO. Penis sits on top of the soft tissue of the femur. Okay. Will there be some bone in there? Probably. But what are we doing here is we're also using the femur as a backdrop. Remember, like in the sternum where we had them rotate?
Heart.
So the sternum was over the heart. Same concept over here. So we're going to use the femur as a backdrop, but also laying out the length of the urethra. Okay. So only two views for voiding. AP for female, RPO for male. Okay? All right, you got this. I just said this. Oh, and here, this is the fun part. For males. Okay? This is also retrograde. But retrograde is so that we can visualize the urethra. If there was a catheter in there, because remember in the retrograde cystogram, we had to put a catheter in there to fill up the bladder. But what if we're trying to evaluate the urethra? We can't have a tube in there. So what they'll do is they'll use this Brody clamp. Okay? So the clamp, this end goes into the opening. This other end here is connected to a syringe, contrast, and then we're just going to shoot the contrast into the vessel. Okay? I actually got a couple of these at home. I wanted to see how it worked. All right, guys, got it? We're done. All right, why don't you guys, Mr. Benoit is going to be meeting us here at 4 o'clock. I mean, we can extend it. What time do you guys want to start?
4 o'clock. What? No.
I want you guys to eat. Go on a break.
Eat.
What?
1, guys. You're
Okay,
crazy.
Look. For those of you who want to start at 4, we can start at 4. Some of you
Okay.
guys can go on lunch. So we'll just stagger in. Okay? So we'll get started around 4 o'clock for some of you guys, and the rest can come start. Just make sure you're nourished and drink lots of water, okay? Because we want your veins to be plump.
Dr. Radt,
Yeah.
what's the latest I can come?
Ladies, you can come back.
Yeah, well, the latest you can come back.
I mean, we're still going to be setting up. So
Oh, sorry.
4:15, 4:20, 4:30. Yeah.
Have it here.
For
I
50?
mean, what I'm saying is we're going to get started at 4. We need people to be here at 4 to get started. Are we going to be able to get all 3 of those? No, because we have to do our stations. It's going to take a while for us to go through.
So my first story will be fine, right? Yeah, thank you.